Assalamu alaikum. Hello, dear friends. I'd like to introduce a new series of videos about hospital policies and procedures, which are written instructions on how staff members do different processes. Policies are general rules that govern our performance, and procedures are sequential steps on how we do it and the responsible person for each step. In this video, we will talk about assessment and management of pain. For more videos, please visit my Facebook page, Healthcare Quality, and my YouTube channel, Dr. Hassan Kamel. If you like it, please support me with likes and follow. Application. This policy is applied in all patient care areas. Purposes of this policy. Number one, to establish a standardized process for the appropriate pain assessment and management for all patients. Number two, to provide clinical practice expectations and guidance to facilitate individualized, effective pain management to enhance patient quality care, promote optimal outcomes, and facilitate patient family satisfaction utilizing the latest evidence-based practice. Number three, to provide an atmosphere of caring and to ensure each patient right to appropriate assessment and management of pain during the stay at the hospital. Number four, to make hospital staff understand the personal, cultural, and societal influences on the patient's right to report pain and accurately assess and manage pain. Number five, to fulfill hospital ethical commitment to patient, family, and community about active participation in medical decision-making. Number six, to assure compliance with Bill of Patient and Family Rights and Responsibilities, and to provide a patient-centered quality health care which meets international standards. Definitions. Number one, for the purpose of this policy, adult patient is a patient aged 12 years and older. Pediatric patient is a patient younger than 12 years of age. And neonatal patient is a patient younger than 28 days of age. Number two, pain, an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Acute pain, brief, physical cause usually known, pain subsides as healing takes place, intensity can range from mild to severe, associated with tissue damage, inflammation, a surgical procedure, or a brief disease process. Chronic pain, malignant or non-malignant pain that exists beyond the expected time frame for healing or where healing may not have occurred. Chronic pain worsens and intensifies over time and persists for months, years, or a lifetime. It accompanies disease processes such as cancer, arthritis, fibromyalgia, and diabetes or an injury. It can be subdivided to neuropathic and nociceptive. Procedural pain, is pain and/or discomfort from diagnostic or therapeutic procedures such as lumbar puncture, bone marrow aspiration, wound and burn debridement, incision and drainage procedures, needle aspiration of fluid or air from the chest or abdomen, venipuncture, etc. Post-surgical pain, pain associated with surgery and trauma. Number 3, pain assessment, an ongoing complete systematic process of identifying pain severity and location and its characteristics, including response to treatment. Number 4, pain management, interventions intended to prevent, alleviate, or eliminate pain and maximize patient functioning. Number 5, communicative patient able to provide a self-report. Number 6, non-communicative patient unable to provide a self-report verbally or physically. Number 7, comfort function goal, the pain level on a self-report pain tool identified by the patient at which the patient is able to perform necessary or desired activity easily. This goal is identified when patient presents for care or admission. Policy statement. Number 1, it is the policy of the hospital to maintain patient right to receive effective pain management based on appropriate assessment, to decide the extent to which family participates in their pain management efforts, to be informed that effective pain relief is important and that they should inform treating physician or assigned nurse of any unrelieved pain or discomfort, to be encouraged to take an active role in their pain management and assisted to set realistic pain relief goals. Number 2, pain should be assessed for all patients in all clinical areas. If patient's assessment reflects that pain is present, a comprehensive assessment and reassessment should be documented in the patient medical record. Number 3, this policy represents the minimal standards of care at the hospital regarding pain assessment and management. Unit or specialty specific protocols or standards of care may be developed provided the minimal standards outlined in this policy are met, appropriate to that patient population. For example, palliative care, post-anesthesia care unit, obstetrical units, etc. Number 4, pain assessment and reassessment shall be performed as determined by individual patient needs and as a minimum with vital signs per unit specific standards of practice and interventions or procedures likely to result in pain. Number 5, reports of pain shall be taken seriously. Health professionals will accept and respect the patient's report of pain and proceed with appropriate assessment and treatment. Number 6, upon patient's presentation for care or admission, use the following hierarchy to determine the method for pain assessment. A. Always obtain the patient's self-report in the communicative patient. B. If the patient is unable to provide a self-report, non-communicative, then consider causative factors and exclude any cause of irritability, for example, vital sign changes, hypoxia, hypothermia, etc. Use an appropriate comfort measure to reduce irritability if found. Change position, decrease light and noise, etc. Identify potential causes of pain, such as tissue injury, pathological processes, conditions, or procedures that typically result in pain. Observe patient behavior's physiological changes that may suggest the presence of pain using the non-communicative pain scale as applicable. For example, in patients who have dementia and unable to provide a self-report. Implement analgesic trial and reassess to determine if behaviors change or resolve. Number 7, only the hospital's approved pain assessment scales shall be utilized. Pain assessment scales shall be selected based upon the patient's age, developmental, emotional, and cognitive status. Pain severity is rated on a 0 to 10 scale. The same pain scale shall be used every time the patient is assessed for pain. The pain scale shall only be changed if there is a change in the patient's condition in a way that doesn't permit the continued use of the scale, such as the development of a cognitive impairment. Number 8, the physician and/or nurse shall collaborate with the patient or caregiver to determine the rating of the comfort goal on the pain scale considering activity of daily living. Number 9, in the case of non-communicative patients, if no comfort goal has been established, then less than 3/10 shall be aimed for as applicable to patient's condition. Number 10, all healthcare professionals are responsible and accountable for ensuring effective pain management and prevention is carried out as applicable to their practice. Number 11, measures of pain control. A. Pharmacological measures include opioid and non-opioid analgesics, non-steroidal anti-inflammatories, corticosteroids, drugs for neuropathic pain, and anti-migraine drugs. Routes of administration include oral, rectal, intranasal, topical, transdermal, intramuscular, subarachnoid, epidural, peripheral, subcutaneous, and intravenous, including patient-controlled analgesia. B. Non-pharmacological, including distraction, imagery, preparation through play for children, music, physical applications of heat and cold, rest, immobilization, alteration of environment, movement interventions, 85% sucrose simple syrup for neonates, and comfort measures, for example, touch, rub, massage, breathing techniques, etc. Number 12, appropriate pharmacological management shall be implemented based on a complete patient assessment. Choice of therapy is directed by the severity, type, and cause of pain. A sequential approach, such as that developed by the World Health Organization three-step analgesic ladder, is recommended. Number 13, the effectiveness of pain management will be evaluated by treating physicians, assigned nurses, and other healthcare professionals caring for the patient, and findings and assessments shared between the disciplines to optimize further management. Number 14, the use of placebo for patients during clinical practice is not acceptable. Number 15, the physician shall incorporate a comprehensive pain assessment into the history and physical assessment for patients with a pain score greater than 0. The pain history and initial assessment shall include the following elements as applicable: severity, location, character, onset frequency, variation and patterns, comfort function goal, alleviating and aggravating factors, pain management history including medication history, past interventions, and response to treatment, present pain management regimen and effectiveness, effects of pain including impact on activity of daily living for chronic pain only, physical exam and observation of the pain site. Number 16, in outpatient clinics or units such as day surgery unit or pre-anesthesia unit, all patients shall be assessed for pain during the initial assessment and during each subsequent encounter. If pain is present, assessment shall be performed as outlined in step 4. Pain is reassessed during the visit if applicable. Number 17, for emergency room patients, all patients presenting to the ER department shall be assessed by the triage nurse for the presence of pain during the triage process and documented on the patient medical record. Triggers for notification of the physician shall include pain suggestive of a potentially life-threatening process, for example chest pain, or acute pain severe enough to warrant placing the patient into a higher triage priority. Pain assessment shall be performed for all patients with a pain score of greater than 0 and shall include the pain scale used as outlined in step 2. Evaluation of pain and underlying cause for pain shall be assessed by the emergency department physician according to the guidelines outlined in step 15. Patients triaged with pain score of more than 7 per 10 should be assessed immediately by the fast-track physician and appropriate intervention to be given immediately within 30 minutes. Reassessment of pain shall be done by both physicians and nurses continuously throughout the patient's stay and to be documented in the patient medical record. Frequency and thoroughness of the assessment shall be done based upon the initial assessment, interventions, and changes in the patient pain status. Number 18, frequency and thoroughness of assessment reassessment shall be based on one or more of the following: presence or absence of pain on previous assessment, severity of pain, presentation of new pain or significant change in pre-existing pain, suitable interval after interventions as outlined below, adverse effects of pain management regimen. Nurses shall reassess and document the effectiveness of the pharmacologic, non-pharmacologic, and interventional therapy as outlined at the following intervals in the appropriate patient medical record, unless deemed necessary, to assess in shorter intervals using criteria or factors mentioned before. Oral medications or PR, 60 minutes following administration. Intramuscular medications, 30 minutes following administration. Intravenous medications, 15 minutes following administration. Non-pharmacologic interventions, subject to the treatment choice. Interventional therapy, subject to the treatment choice. Number 19, all post-operative patients require scheduled around-the-clock analgesia for at least the first 24 to 48 hours post-operatively. This may be in the form of continuous IV infusion or oral opioid. Number 20, the effectiveness of the pain management treatment shall be evaluated on an ongoing basis and modified based upon the assessment findings. Persistent, unreleased, uncontrolled pain shall be communicated by the nurse or healthcare professional to the physician. If pain score remains consistently above the patient's acceptable level, a review of the treatment regimen and a modification of the management plan shall be considered. Pain ratings which continue to be at an unacceptable level post-modification of the treatment regimen shall result in a referral consultation to the pain services or palliative care as applicable. Medications for persistent pain should be administered around the clock. Number 21, non-pharmacological and interventional therapy. It should be selected based upon patient condition and preference, cultural acceptance, and developmental age, effectiveness of prior use, pain and anxiety level of patient and caregiver, and the ability and willingness of the patient and caregiver to follow instructions and degree of pain relief obtained. Non-pharmacological interventional therapy may incorporate multiple modalities and techniques such as physical, psychological, and interventional therapy. Number 22, education regarding pain, its management, and the patient's role in assessment and management are provided on an ongoing basis. Number 23, patients and the family are informed when procedures, medications, or other treatments can be expected to cause either immediate or delayed pain and are informed about the importance of reporting pain. Number 24, patients are provided information on interventions to prevent or alleviate pain, including the reporting and management of potential side effects. Number 25, patients charged with pain shall receive education related to pain management as part of the discharge planning process. Specific instructions regarding pain management goals, anticipated degree of pain, interventions to be used at home, contact information for questions or problems relating to pain management, instructions for pain medications. Number 26, education provided shall be documented in the appropriate patient medical record. Number 27, staff education, nursing and medical staff, as applicable to their role, shall determine the method and time frame for educating their staff. Then we come to the procedures and responsibilities. First, in non-surgical cases, number one, patients and the family are informed of their rights to appropriate assessment and care of pain and are assured that their report of pain is taken seriously, done by the treating doctor, assigned nurse, and patient educator. Number two, staff nurse shall inform all patients that effective pain relief is important and that they must inform any unrelieved pain or discomfort. Number three, pain screening shall be done as part of the initial nursing assessment and documented. Number four, if the patient confirms current or recent pain, they will be asked to rate it using the pain score, FACES pain rating scale, and a pain assessment and follow-up sheet will be initiated by the assigned nurse. Number five, the comprehensive pain assessment performed by the nursing staff shall be documented on the pain assessment form in the patient medical record and shall include the pain scale used and the following elements: severity, locations, character, frequency, comfort function goal, and what relieves the pain. Number six, assigned nurse will inform the treating physician if pain screening is positive for additional treatment. Number seven, nurses shall reassess all patients for the presence of pain at time of vital sign reassessment as the fifth vital sign and document on the pain assessment form in the patient medical record. Number eight, physicians shall address pain status daily during the inpatient rounds and when the patient experiences new unrelieved or worsening pain, the treating physician will consult the pain specialist and shall document the assessment reassessment in the progress notes. Number 9, treating physician shall document the management orders in the medication sheet based on the pain assessment as initial analgesic order, subsequent orders based on the patient response to pain relief measures. Number 10, patients who are ordered to have PRN medications should be assessed for the need for medication at time intervals specified. Number 11, chief pharmacist shall make sure that all recommended analgesics, including non-steroidals, non-opioid, and opioid, made available in the pharmacy and entered in the hospital drug formulary. Number 12, patient educators and social workers will assist with pain management or referral initiated by treating physician or assigned nurses. They must assess family dynamics and patient family and social network and support structures, reinforce pain and symptom management aspects of preoperative teaching with patients and families. Assist patients and appropriate family members to clarify pain management needs and preferences with medical and nursing staff and encourage patient and family members' involvement in the pain management process. Attempt to minimize anxiety stress due to potential or actual pain discomfort and document assessment, interventions, and evaluation data on their form. Second, surgical cases. Number one, in the pre-anesthesia visit, the patient is informed about the possible plans for post-operative method for analgesia, whether systemic or interventional method will be used by the pain specialist. Patient has to talk to the pain physician who has to explain to the patient thoroughly all the details about the intervention, expected outcome from the intervention. Patient had the right to decide with the physician which method he prefers for the post-operative analgesia based on the discussion he had with the pain specialists and knowledge of the possible side effect of every technique. Number two, pain management physicians should determine and apply non-pharmacological versus pharmacological interventions per protocol based on age, gender, culture, background, and history. This starts from the OR in the recovery room. Number three, post-operative analgesia medications should be written in the medication sheet before the patient discharge from the OR. Epidural infusions should start in the post-anesthesia care unit. Number four, patient discharge from the post-anesthesia care unit should be done when the patient is having a pain score less than 4/10. Number five, nurses administer doctor's order on pharmacological interventions according to pain assessment. They reassess the effectiveness and document on pain flow sheet within 30 minutes to 1 hour. Number six, nurses teach patients and the family members the importance of communicating pain and discomfort and how to assess and manage pain using appropriate pain assessment tool. Number seven, nurse informs the attending pain specialist if pharmacological and non-pharmacological interventions are not effective within 1 hour. For example, patient is still having moderate to severe pain. Number eight, to terminate the acute pain management service, a post-operative analgesia prescription is delivered to the patient, family member, or left in the patient file to be given at the time of discharge from post-anesthesia care unit. Anesthesia doctor in charge will write down in the physician notes his plan for pain management. Number nine, treating surgeon will take over pain management for 48 hours from surgery, except for patients on continuous epidurals should be done 24 hours after weaning. Attachments 1. Pain assessment scales. 2. Nursing pain follow-up form. And we have also additional forms for assessment of pain, acute pain, OR pain, severe pain, chronic pain, and intrathecal epidural analgesia. Approval of each policy is usually done by the preparing person, recommended by the department head, reviewed by the nursing supervisor, and approved by the quality director, medical director, and hospital director. Thank you.